and he is a senior consultant in Corneal at Chaitanya Eye Hospital, and also he is a visiting consultant at Alfonsa Pala and Todupuzha and Jyotis Eye Hospital, Kannur. And he is MS FRCS Glasgow, and following his fellowship he did work a decade of working in Alexandra Health in Singapore. Over to Sachin for his case of behind the blur corneal edema following cataract surgery, which we often come across.
Yeah, good morning everyone. Thanks Dr. Anita for including me in this IC actually. So this is actually a clear and present danger for all the cataract surgeons. We all must have come across this thing at some point of our career. So we have a 58-year-old female patient with pre-existing FACD. So this is actually a condition which we always come across. I mean, we have a fuchs, but whether to do the cataract, whether to go ahead with the cataract. So all of us will have a our own nomograms, like whether to go ahead. So in this kind of a cell pattern, if the cell pattern is maintained and the count is almost around 1,500 and the CCT is quite okay, we go ahead with the cataract. And it was an uneventful phacoemulsification with foldable IOL. 1 week post-op UCVA was 6.9, so everything was going fine. But 2 weeks post-operatively, the patient presents with the corneal edema. I mean, you from the anterior segment OCT, if you can always make out it's a shallow DMD, you can see that. And the first thing will be like at this point, it's a central DM detachment by all the regimes. We can actually go ahead with the decimetopexy with the diluted C3F8. The videos is courtesy Dr. Jason actually. So here he is actually putting the isoexpansel C3F8 14%, and he's entering in an area where there is no DMD actually. I would have preferred to use a needle, but he's actually using a side port, and with the cannula he's inserting the bubble. So almost 60 to 70% bubble, and that's it. The procedure is over. So initially, the 1 week till 1 week review, the cornea actually cleared up and the DM was attached. But 2 weeks later, the patient again presented with a shallow DMD. So at this stage, we have to actually think about what to do. We actually went ahead with a repeat decimetopexy. I mean, C3F8, but this time we added that vending incision actually from the top. Again, I mean, there was a you can actually see that there is a little bit of C3F8. It must be partly because of the, which is in the AC left. So we just augmented it with a little more bubble, and there is, and after that, a small vending incision on the top. Right. But again, we were not very fortunate. From day one, the DM was found again bullous. So you can see that. So this is a desperate situation, which we have already done decimetopexy twice. So desperate situation, desperate measures. So we went ahead and did, you can see that through and through suturing, something like a compression suture, which we do for high drops in keratoconus. You can avoid the pupillary axis and then put 2 interrupted 10-0 nylon sutures and tight suture, of course. I mean, you have to be very sure that the DM is included. Fortunately, this point, the DM started clearing. You can actually see the anterior segment OCT where the suture augmentation you can see clearly. Right. So the DM was found attached from then onwards, and on 1 month follow-up, we removed the sutures. And there was a little bit of shallow DM wherever the suture was removed. Actually, you can see that here. But after 2 months, it was found completely attached, and the UCVA was 6.9. You can see a small DM rip at below the pupillary axis. So that's the case. Now I'll give a little bit of this thing. So a little bit on the physiology of corneal hydration. I mean, you know that corneal hydration is maintained by the lattice arrangement of the collagen fibers, the famous Maurice theory, and the destructive interference, and the corneal hydration controlled by maintaining of the endothelial level. So if any of these molecular pumps or any of these mechanism is altered, you have an edema. So what are the etiology and risk factors of post-corneal? I mean, this is a paper from Dr. Namrata's paper actually. She has explained it very clearly. I mean, slit lamp examination, from that point onwards, we can actually identify the points which can lead on to this condition. Actually, shagreen is something which we have to look for, anterior and posterior shagreen. FECD is like pretty clear. You can actually make out guttae nowadays, and most of the centers will have a specular to rule out this condition. During the surgery, this is the step usually where we have DM detachment. That is the hydration step. A side port hydration is the one which usually results in DM detachment. Post-op, any vitreous in AC or AC IOL touch and TAS is something which is usually can cause DM detachments. So these are the identification risk factors for this condition. And diagnostic tools, as I said, all these things are available with you. It is just that you have to make an extra effort to look at all these things. Slit lamp, pachymetry, specular. If you don't have a specular, pachymetry is a useful tool to manage to identify the progression or identify the risk factor. Anterior segment OCT, if it is there, it's always better to take it before. Now, clinical presentations, we all have our own grading of the SK, this trikeratitis, from 0, transparent, clear, from +1, +2, +3, +4, where there is marbling, you can't see the endothelium at all. And this is a usual classification by Susan Jacob, recent classification. It's a clinical classification, and it's based on the anterior segment OCT picture. It's very useful because, you can change your management strategies based on this. So the first one, you can see that the A is a regmentogenous detachment where you have a break, and the DM is actually floating, or it's free floating DM. And B, you can see the bullous detachment, where there is a bulge into the AC. Here is the one which it will be helpful to do a fluid venting along with the bubble. And this one is a tractional detachment where you have a taut DM. That may not be helpful if you have a fluid venting. And complex is like multiple types together you can see in a single case. Right. So management strategies, again, I'll take a small table from Madam's paper in IGO. If it is an immediate onset of corneal edema, and usually it is because of an endothelial trauma because of the surgery. So you can start with medical treatment, and if it progresses and if there is a structural lesion like a DMD, you can actually go for decimetopexy. And if it worsens, then you can plan an endothelial transplant. Medical therapies, usually it's topical hyperosmotic agents. We have a ointment and drop base. You have to be pretty generous in this. I usually give 3 times, and the drops also. And corticosteroids, liberal use, anti-inflammatory agents, and also AGM also if it is needed. This is a good algorithm, Dr. Kumar's paper in JCRS 2015. It's called HELP regime. Actually, decimus membrane detachment based on the height, extent, length, and the pupil. You can base it whether to do the medical management or directly go for surgical intervention. So that if you want an algorithm or something to follow on how to go ahead with the thing, this is pretty good actually. So the methods we discussed, the first one is the normal decimetopexy. Even Dr. Namrata has got a staging actually. If it is like a rolled decimates, we can do she also got an algorithm for how to go ahead with the decimetopexy. So, and the second one is that it's a Chinese paper actually. This is the one which we used in our case, which is the fluid venting with the 23 gauge needle along with the air bubble. So these two you can, I said, because if it's like a bullous DM detachment, you can actually do a fluid venting. Other surgical options, this is actually more for a chronic case. Like, if you have a localized bullous keratopathy or this, then you can actually go for anterior stromal puncturing or diamond burr, or even a PTK actually at the end. But definitive treatment, definitely you have to go ahead with an endothelial keratoplasty. In the first one, you can see a Barron's artificial chamber. You can make the donor cornea. You can have a lamellar separation with that. Right. Yeah, we're making almost like a dalk here. And then after separation, then you can in the recipient's cornea you can do a decimetorexis, and then inferior PI you'll do, and last but the posterior lamella you can just insert into the AC with the 30 gauge needle and an air bubble tamponating. That's it. So that is the DSEC for you. And a little more refined technique is DMEC. It needs a little more learning curve actually, because we are removing the DM specifically and inserting it into the AC with devices. Right. So as a conclusion, corneal edema following cataract surgery, as I said, it's a clear and present danger. It's an untoward but avoidable complication. Causes, you have to understand the cause, and accurate diagnosis is very important for the management, and a careful preoperative workup, intraoperative precautions, and vigilant postoperative care, it avoids this complication, and because this it can save the surgeon from patient's error as well as medical complications. Thank you.